Awesome. So welcome. Hi, everyone. For those of you guys who don't know me, I'm Jason Bloom. I'm a facial plastic surgeon outside the Philadelphia area. Today with us we have Donna. She is a 64-year-old young woman. Donna's son is a good friend of mine, and he's a lot bigger and stronger than I am, so we're going to make sure we make her look really good today. But we're going to go through a couple different things. In this first session, we're going to talk about mainly a little bit of using Dysport neuromodulator in her glabellar area, as well as using Restylane Lift in the midface area with a cannula. And I like to use both cannula and needle when I'm injecting the midface in my office. So when Galderma got the FDA approval for use of Restylane Lift in the midface with a cannula, I was really excited because I do a lot of trainings. What this is doing is it's allowing you guys to get into my office, basically, because this is exactly how I would inject Donna if she entered my office and we were injecting her midface. I would do it in this exact same way. I use a cannula where I need it, and I use a needle where I need it. So let's first talk a little bit about the midface, and I know you guys talked about anatomy, but let's see, Donna, can you sit up just a little bit? Let's get a close-up view of her midface. Perfect, and look straight ahead. Perfect. So a couple things. She has a little bit of facial asymmetry in her fat loss and tissue descent. So you can see when you look at the lid-cheek junction, it's a little bit higher on her left side, and it's a little bit lower on this side. Additionally, she's lacking a little bit of volume on either side, and this tissue is mobile, right? And you can sit back for me. So a question I get asked a lot is, you guys just went through the anatomy looking at the fat pads of the face, and you're looking at deep fat pads, and you're looking at superficial fat pads. So a question that I get a lot is, how do you know when it's superficial? How do you know when it's deep? And how do you make sure you're in the various fat pads? So an easy answer to that question is, if you can grab the tissue and it's mobile, it's a superficial fat pad. All of the deep fat pads of the face, as you guys just saw, are stuck down to the bone, right? So I like to use a needle first to tack up, and there's a lot of debate out there is whether fillers can actually tack or lift. In my mind, they absolutely can, but you have to literally use them as kind of tacks when you're tacking up the face or lifting it, and then I use a cannula to provide volume over top of it in a more in a pattern throughout the anterior and lateral midface. So, I go around and I do these trainings, and I ask people, I like to focus on 3 W's, and if you've ever heard me talk, you've heard me say this, and the 3 W's are the what. So understanding the rheologies, the physics, how these products are made, and the different technologies, right? So we have NASHA technology, non-animal stabilized hyaluronic acid, which is your Restylane Lift, your Restylane L, your Restylane Silk. And that I use for structure, definition, precision, lift, right? Those are strong lifting fillers because they're based on high G primes, right? That's the amount of resistance to deformation that these products give. And then on the other side is your expression technology, your refine and define. And those don't lift as well, but they get into the tissues better. They're more flexible. So I like them in areas of the lower face where you're talking, kissing, chewing, smiling, doing all those things. You want a filler that's going to incorporate well into the tissues and not necessarily be as bulky in certain areas. So I ask the second W, which is the where. So it's important to understand the anatomy. You guys just went through a lot of the midface anatomy, but not just the where in terms of like where on the face, but also the where in terms of what level. Are we injecting this in the dermis? Are we injecting this supraperiosteally? Are we injecting this in the subcutaneous tissue? Right? So you need to know where's tiger country, basically, where are the areas we need to look out for, and also the areas where we have to understand where these larger vessels run. And then finally, the most important W in my mind is the why. Why are you doing it this way? And my way might not be the best way, and I go around and I try to find out. I learn as much from doing trainings and speaking things as any of the attendees, because I ask, I understand these products, and if you have a better way, I want to learn how to do that. So one of the first questions I ask is, when I'm talking about the midface, right, I say, where would you start? Where is your first starting point? So again, when I'm injecting the midface, I don't start with the cannula. I like to start with a needle. And I say, would you start here? And people say, yeah, I like to start here because it gives me a good amount of lift. Do you start here over the zygoma, or do you start here at or around the malar eminence area? And a lot of people say they start out here, and then I ask them why. Why do you do that? So when I'm doing midface injections, I tend to start a little bit more anterior here. People can draw lines, and we'll go through the lift and contour lines, but everyone has a malar eminence, which is the most anterior projecting portion of the cheek, and you can feel it. And I like to start just inferior and lateral to that point. The reason being is, if you think about levers and pulleys, right? Think about a physics equation. Is it easier to lift something, meaning less force, if your fulcrum of that lever or the pulley is closer to your target or further away? So I want you to think about that for a second. When we're doing midface injections, our target is really this anterior midface and the nasolabial fold. And I say, just put your finger here where I would start and pull. And pull in a perpendicular line, and look at the distraction of the midface and the nasolabial fold. And then put your finger here and distract. Where did we get more distraction of the nasolabial fold in the midface? The answer is when we're closer. And so I say, why do we start here if you get more lift, and I just showed this on her face, if we start here? So I do the exact same injections that pretty much all of you guys are doing, except I start here and work laterally rather than starting lateral and working medial. Why a lot of people want you to start lateral is so that you use a lot of product laterally and need another syringe by the time you get anteriorly. So don't take my word for it, but when you go back to your practices, try this, and I will say you'll get better results. You'll probably use less product, and your patients will be happier. Another reason, and the last reason, and I'll get to injecting soon, that I start a little bit more anterior and work lateral is because this is the lateral aspect of the deep medial cheek fat pad, right? That's a really important fat pad. So you guys went through the anatomy, and you know about the facial fat compartments article, which is really land-breaking, groundbreaking article by Rourke and Pessa at UT Southwestern. Well, they actually wrote a lesser-known article that was a follow-up article, and it was called The Deep Medial Cheek Fat Pad, A Youthful Cheek. And what they showed is they took those same cadavers that were dissected with all of the fat pads, and they just put some saline in this fat pad right here, the deep medial cheek fat pad. And just by injecting that one fat pad, what they showed is that there were 4 improvements to the face. Number 1, as I said, the nasolabial fold improved. Number 2, the lid cheek junction improves. Number 3, they got an improvement in what they called the V-shaped deformity of the face. And number 4, they got a natural looking cheek, right? So the key to natural looking injections is deep injections into the deep fat pads. Because we all see these people walking around our cities, towns, and neighborhoods where they just have so much superficial filler, you lose the natural contours of the face. So by injecting deeply onto the bone, the face and cheek naturally lifts. So the face should have natural contours. It should be convex at the temple, concave at the lateral orbital rim, convex at the cheek and then concave again at the buccal area or the submalar area. So that's how I do it. I'm going to demonstrate it. But first, we're going to inject a little bit of Dysport in this patient. So this is the on-label 50 units of Dysport. We're going to inject it in her glabella. So Donna, would you bring your brows together? Good. We're going to put 10 units in her procerus. Good. Bring your brows tight together. I see that where the skin is dimpling, that's where the corrugator's inserting on the skin. We're going to put 10 units at the head and 10 units at the tail of the corrugator, and the same thing over here. 10 units at the head, 10 units in the tail of the corrugator. Perfect. Relax. Okay. So now we're going to start with a little bit of Restylane Lift. And like I said, I like to use the needle first. And this is the 29 gauge needle that comes with it. And I'm feeling the malar eminence. And I like to work in a perpendicular line. Also, based on physics, a straight line has the most mechanical advantage. So I distract the skin with my other hand, my offhand, and I'm going to inject here, touch the periosteum, and I'm going to put a small aliquot down. Just a slow injection. I'm watching the soft tissue. Okay, and I'm going to come out and I'm going to come about a centimeter posterior to that, again on the bone. Small little aliquot. And then finally, a third aliquot on the bone higher up. Perfect. Okay, now I'm going to come around to the other side and repeat that exact same on this side. Again, you find your nasolabial fold, you're going to work perpendicular. You find the malar eminence a little bit inferior and lateral. I'm going to pull with my opposite hand onto the bone. Small little aliquot. Does anyone have any questions as to what I'm doing? Okay, small aliquots. And then one more. Onto the bone. Great. Now what I'll do is I'll use the cannula. I'm going to put a little bit of lidocaine with epi to mark my insertion site. So we know, and you guys have just learned, there's 2 spots for the insertion site. So if you come, I use the contour a little bit more than I do the lift, but if you come a centimeter lateral to the lateral canthus and drop a perpendicular down, and you come lateral to the alar base right here, that's our contour site. And so I'm going to put a little numbing aliquot here, and that's just a little skin numbing. We're going to do the same thing on the other side. So Donna, turn towards me a little bit. About a centimeter over and a centimeter. Just to numb the skin. And then you guys also learned about the lift cannula insertion point, right? Which is if you draw a line from the helical root to the alar base, and then another line, you can feel the orbital rim, about a centimeter lateral to that, perpendicular to the jaw. This is going to be the lift insertion point. But we're not going to do that today because I achieved my lift through my needle injections. But the contour point is now just going to be used in order to give volume to the face. So what I'm going to do is now we're going to use the cannula midface, and this is a 23 gauge needle. Come in right at that contour site. Did you feel that, Donna?
Not at all.
Okay. Just give it a second. And I'm then going to use, I use a 25 gauge inch and a half long cannula for these injections. This I just think is the best amount of length to sturdiness. So some of them, the 27s for me, get a little bit flimsy. And the key to using cannulas is pinching the tissue and pushing in a perpendicular direction. So when you find the entry site, sometimes hard to just get through that dermis here. Okay? And I'm pinching and I'm injecting and I'm moving the cannula into the plane I want. So I'm underneath the deep fat pads. So people say, are you on the bone? What level am I at? So by lifting up the tissue, the superficial fat pads are up. I'm now lifting the tissue, sliding the cannula. So the cannula is all the way up here. Right here it's on the bone, but you can be in different planes as long as you're kind of at the superficial fat pad, deep fat pad junction, essentially. And what I'm doing now is just fanning the product and layering it throughout the midface on this side. Again, picking it up, laying it down, coming laterally. I'm going to use about a cc of volume on this side. Again, if you're meeting a little resistance, you're either too superficial or too deep. Just see where we are. Good. Okay. Now I'm going to come around and inject the other side, also with a 25 gauge inch and a half cannula. And a little poke here. There's got to be some questions. Where are all my friends at? Okay, I'm working, I'm a one-man getting all my stuff today. All right, so we're pinching up the tissue. Again, same thing. We're finding that needle entrance point. I'm pinching the tissue, pushing just to get through the dermis. I'm into that anterior midface. I'm still deep to that superficial fat pad. Kind of inject a little bit backhand so you guys can see it. Actually, no, I'm coming around this way. And now we turn towards me a little bit. Perfect. So now that I injected the anterior midface a little bit, I can have her turn and inject from this side. It's probably a better angle for the camera as well. And inject this lateral midface. And so when I lift up the superficial fat pads, I mean, my cannula tip is out here, right? So that's way up here, and that really does help lift up the tissue and provide volume over that lateral zygoma. Now, I will say one more thing about the mid-face cannula, and that's, I just want to see how we're doing. Because she had a little bit more volume on that side to start. Probably put just a little bit more on this side. Is that cannula, it hurts a little bit less. However, if you have a patient that's a little bit prone to like getting a little vagal during injections, the cannula certainly feels a lot weirder in your face. So in those kind of patients, I tend to inject a little bit more with needle because they don't have that sensation of the cannula tracking, which can be a little bit strange to some patients. So the question from Columbus was, can we have the patient talk about pain and discomfort?
There is none. There's no pain or discomfort.
See that, Columbus? Painless doctor. So we completed the mid-face injections, and we're going to kind of move on, and let's just get a close-up of her mid-face before we kind of move on. So the question from Benita Springs was, how can you use less product starting anteriorly instead of from a more lateral approach? The answer is because if you get enough lift coming from medial to lateral, you're going to see that there's going to be improvement better with less product versus using a lot of product laterally where you would have to use more in order to achieve the same lift as you come anteriorly. Does that make sense? Perfect. Again, I don't have the answers, but I would say try this in your practice because it might help. How does she look? You look great. Okay. Okay, so we're going to move now to injecting the hands, and I'm going to take a seat. So usually what I like to do is assess their hands in kind of this neutral position here, and I like to sit while I'm doing hand injections. We have like a pillow, or you can use the Mayo stand. This Mayo stand had a little lip on it, so you have to be aware sometimes it hits the patient's wrist and it doesn't, it's not comfortable. So a pillow sometimes works, a tray table, those kind of things are great. We're just kind of using a pillow in this sense, in this situation. But we're going to inject these 4 spaces here in between her extensor tendons. And so if you've injected the hands before, you know that the dorsal superficial lamina, which is the layer that we inject, is very superficial. It's about 1 millimeter underneath the surface of the skin. So the dorsal superficial lamina is this kind of layer that, as you can see here, I'm moving the tissue over her hands and it's sliding. It's an avascular plane. The dorsal intermediate lamina, which is deep to that, which is deep to the dorsal superficial fascia, has the both the nerves as well as these veins of her dorsal hand. And then there's the dorsal intermediate fascia, and then below that is the dorsal deep lamina, which has the extensor tendons. So you can see the tendons here. So this is a very superficial injection. Additionally, deep to that is then the interosseous spaces with the metacarpal bones and interosseous muscles. So what I like to do is I make sure that this is primed.
Can we address aspiration with cannula and needle?
Oh, okay. Before we get to that, the question is, can we address aspiration with cannula and needle? Yes. You can aspirate with both. I don't do a lot of aspiration. I know that some people only aspirate. Not everyone is the textbook, obviously, but I just rely on the anatomy and knowing where I can inject on the bone and where I have to be in the more superficial soft tissues. So it is, it's a lot easier to aspirate with a needle just because the distance is longer. But Rob Schwartz, a friend of mine who is an oculoplastic surgeon here in New York City, wrote an article that's coming out in the Oculoplastics Journal that he took his own blood into test tubes, and he basically tried every single hyaluronic acid filler on the market, and he aspirated straight out of the tube to see how long it took to get a blood withdrawal, and it was on the order of 5 seconds or more. I think 5 seconds was the quickest it got to get quickest it was to get a flash of blood. Now everyone's seen it with these products. I tend not to aspirate. You can aspirate in the hands. Maybe I'll do that to show you, but it's a lot obviously easier to aspirate with a needle just because the distance is shorter, but at the same time it's a lot easier to get into a vessel with a needle than it is with a cannula. Okay. Chris disappeared, so I'm going to continue injecting. All right, so what you want to do, as I'm just trying to give you guys the best camera angle, is we'll start laterally here in this interosseous space, and what I like to do is just tent it up. I'm going to come at it, 1, 2, 3, just slow injections, probably about 0.1 to 0.2 per aliquot. I'll move over here. Again, I'm tenting up the skin. 1, 2, 3. Let go. Small little manipulation. Put some here. This is all based on just looking around and seeing where she needs a little bit of volume. Pinching. And on average in my office, I tend to use about 1 cc per hand. And we have great data now that says a cc to about a cc and a half, it should last about a year. And really, one of the keys to injecting hands, I think, and marketing it is injecting it as a package. I don't like to sell them by the syringe. I just said, if you want your hands injected, this is how much it is. And you can discount the syringes a little bit because, it is 2 syringes. It's a little bit more than patients necessarily would normally spend on their face. But I like to recommend 1 syringe per side. She needs a little bit more over here. I'll show you at the end, picking up.
They want to see the after effects of the cheek and the hands.
Okay. Okay. There's many different ways to inject the hand. I just like these small kind of aliquots. Donna, will you kind of ball up your hand into a fist now a little bit? And I'm going to do a little bit of kind of manipulation, just some gentle massage. And it helps to kind of massage it down towards the knuckle area, because that's where most of the volume loss is. Okay, I'm just gonna, okay, and you can relax. I'll have you switch hands. I'm gonna massage it one more time. Just kind of drape your fingers over the, yes, perfect. Okay, again, picking it up. Small little injections. Any more questions about this or even the mid-face injections?
I think I have a question with the cheek. What was the average syringes that you used per cheek?
So the question was, how many syringes on average, on average in my office do I use per cheek? Yeah, I mean, I think for the mid-face, on average, I will use 2 to 3 syringes. One syringe is just to tack it up, and I'll use a half per side. And then the other syringe or 2 is to add volumization. So, and that's why I like to come in at that perpendicular angle, touch the bone, get that kind of tacking sensation, and then the second syringe is really just to add volume over the rest of the midface. And you can use the cannula to adjust for small amounts of volume differences between the 2 sides of the face. Donna, how is this for pain?
There's no pain. Little pinch once in a while, but it's nothing.
We're doing great. Okay, almost done here. Chris, do we have any like arnica gel or? Okay, almost done.
There's no pain.
Okay. Great. So I'm going to take now. Let's make a fist with that hand. I'm just going to kind of massage it out. See, you didn't know you were going to get a hand massage too.
No, I did not. This is an added perk.
And then we're going to come back and inject the lower face, but we'll give you everyone a chance to see what the hands look like and what the face looks like in just a second. Okay. Okay, let me see this hand. And very little bruising and swelling. When you inject a lot in the right plane, you tend to not get the bruising and swelling just based on the anatomy. We're not injecting at the plane where the big vessels are. Now, not saying you can't get into them. Just ball your hand a little bit more. Good. But if you start out knowing where they live, that's the first step. Okay? I'm going to put a little bit. I do like to massage the midface a little bit. Okay. Okay, maybe let's zoom in a little bit. How's she look? I think pretty good. Then we'll take a look at her hands too. Do you want to show them? We got blurry.
1 second. To refocus, I'm gonna move down to the hands.
All right, and just look straight ahead. Oh, they're moving down.
There we go.
You can see here.
Yeah.
That was just 1 syringe per side. I think it looks really nice.
I want her to sit up slightly so we can see the face one more time.
Yep.
Want me to sit up?
Yeah.
If you can ask the camera to look at the face.
Will you also bring the camera in on her face? A little bit tighter. Okay, and look straight ahead. The awkward silence is deafening.
If you want to tell me, move back with them.
All right, guys, so we'll be back in about half an hour. We're going to inject a little bit into the lower face, the marionette lines, nasolabial folds, as well as a little bit of the perioral lines in about half an hour or so.